Hello, everybody. Welcome to our second lecture in the heart and the cardiac cycle and hemodynamics lecture. So let's just get right into it. So first of all, in order to understand the conduction system and the ultimate cardiac cycle that results from it, we need to be able to clearly identify the nature of cardiac muscles, muscle fibers, like the actual individual cells, and then be able to distinguish that from the skeletal muscle fibers that we've talked about at length in this course as well. So here you have like an actual picture of a histological prep of cardiac muscle. You can see that right here. It has striations. You can see the striations. You can see the sarcomeres and the Z discs and all of these things that you see in skeletal muscle fibers, and it's exactly the same thing. They're myofibrils made up of repeating sarcomeres, and each sarcomere has actin and myosin cross bridges, and you get that crawling effect that we've talked about probably a number of times in this course. Again, what I'd like to highlight here is the differences between the cardiac muscle and the skeletal muscle fibers. You can see visually, for example, cardiac muscle fibers are actually much shorter. You'll also notice that the fibers are not running in parallel with one another by and large, whereas in skeletal muscle they are. There are, and this might be harder for you to notice, but there are far fewer nuclei present. If you recall, there's lots of nuclei in skeletal muscle fibers. Because those skeletal muscle fibers are the products of the unions of several myoblasts, as you probably recall. You'll also notice that there's some spaces, these sort of hollow areas between the cardiac muscle fibers. That doesn't exist in skeletal muscle fibers, which are really stacked on top of one of another over and top. So these spaces that are found between the cardiac muscle fibers are where the capillaries are, like where all of the blood is in order to nourish this obviously very important structure in the body. The other thing that you can't notice as a difference between skeletal muscle fibers and cardiac muscle fibers, based on the picture that I'm showing you right here, is that the cardiac muscle fibers are connected to one another through these gap junctions. So if you recall, the way a skeletal muscle fiber gets activated is through neurotransmitter release from a presynaptic neuron, a somatic motor neuron. In cardiac muscle cells, that doesn't happen. The way a cardiac muscle fiber generates action potential is by the depolarizing or excitatory ions that are present in one cell. So let's say down here, this cell down at the bottom has undergone action potential. So you will know that that means that there's been an influx of cations, mostly sodium, into the cell. That's what causes it to have an action potential. It's exactly the same mechanism that we saw in skeletal muscle. That sodium is able to diffuse through the gap junctions into the next cell. So what's that going to do to the next cell if it gets a whole inflood of sodium and other cations? It's going to action potential. And so you can generate an action potential in this cell not by having another cell signal it with a hormone or a neurotransmitter or something, but rather simply from the flow of excitatory ions from one cell to the next. The reason that this is important, the fact that you can generate an action potential by ion movements from one cell to the next, means that all of the cardiac muscle cells can work in concert with one another. They all work in unison, and that's exactly what you want with the heartbeat. You want this to contract, and then this to contract, and then this to contract. It has to happen in a very specific order, so they all need to work in unison. We want a reliable single contraction. Skeletal muscle fibers, on the other hand, act independently of one another. They each receive their own signal from their own individual somatic motor neuron. So you can, in this way, it's easier for the skeletal muscle because it allows you to control the intensity of the movement of the muscles and the bones. So the big take home here that we need to address is that the myocardium, all of those cardiac muscle fibers in the myocardium, operate as a single functional unit because they're connected to one another by these channels between their membranes called gap junctions. Desmosomes are also shown on this slide, and we've talked about this earlier in the course, I should say. But the desmosomes, again, are there to sort of stitch cells together. So basically it's saying that all of the cardiac muscle fibers are connected to one another by desmosomes and gap junctions. The gap junctions are much more important in terms of defining the function of these cells, though. Okay, so if we look at... Actually, before we even start that, let's just address one elephant in the room that maybe you've noticed. If I say the way a cardiac muscle fiber becomes activated and contracts its muscle is through ionic signals from neighboring cells, because those cells had action potential. But what caused the very first cardiac muscle fiber to undergo action potential? And the answer is it does it itself. So what you see is that there's a very small number of, I can show you over here, there's a very small number of these autorhythmic fibers, which are special cardiac muscle fibers that generate action potentials on their own, just periodically all the time. Only about 1% of cardiac muscle fibers have this capability, and these cells are called pacemakers. And collectively, the arrangement of these pacemaker autorhythmic fiber cells forms something called the cardiac conduction system. So it's a network of these muscle cells, these autorhythmic fibers that transmit electrical signals across the heart in a really ordered manner. And this is what's going to cause the cardiac cycle that we're going to talk about in the next video. So the two nodes that we need to focus on here are the points at which the impulses are triggered for both the atria and the ventricles. So the sinoatrial node is at the more superior region of the heart, and it's responsible for autorhythmically starting the process of generating action potentials out through the atria. And then you have the atrioventricular node right here, which is going to help propagate action potentials out through the ventricles. So of course you can actually see here that this looks like a heart, right? You can see the one atrium, this is the left atrium over here, this is the right atrium over here, right ventricle down here, left ventricle down here. So just very simply, the idea that we're talking about is action potentials start getting generated in the sinoatrial node. They propagate out through the atria, causing the atria to contract. Then they come back to the atrioventricular node, and then they go down through the ventricles and cause the ventricles to contract. The one thing that I want you to consider what's happening as the action potentials arrive from the sinoatrial node at the atrioventricular node is that, look at this here. So the sinoatrial node breaks up into how many different branches? You can see like 1, 2, 3, 4, many branches coming out of the sinoatrial node. But most or all of them come back into one lane. They go back into the atrioventricular node. So think about if you were driving on a highway. It's like a 5-lane highway, 1, 2, 3, 4, 5. And then you all the lanes converge onto a single road. What would happen to the traffic? I hope you would acknowledge that the traffic would slow down quite greatly. And so the traffic's going to slow down, and that's going to allow the atria to complete its contraction before the action potentials reach the ventricles, and then the ventricles contract. There's no point in having the atria contract, and then while it's still contracting, have the ventricle also contract. You want the atria to contract, finish its contraction, then the ventricle contract while the atria is relaxing. Again, we'll have lots of opportunities to see this in the future. Okay, so this is more of a cartoon of what I'm just talking about here. We're going to just go through the whole pathway here. So right here is the sinoatrial node. The sinoatrial node is inferior and lateral to the entry point of the superior vena cava into the right atrium. So here's the right atrium, here's the superior vena cava, and this location here, inferior and lateral to that entry point of the vena cava into the right atrium, is the location of the sinoatrial node. So the point with the sinoatrial node is that it spontaneously depolarizes to generate threshold. So it does it automatically. It doesn't need a signal from the nervous system. It just does. And then it starts through those gap junctions, sending out that action potential to all the cells it's connected to. So this depolarization followed by a relaxation, followed by a depolarization, followed by a relaxation in a very ordered cyclical fashion is what's called the pacemaker potential of the heart. And it's because of these cells in the sinoatrial node. So again, you can see the sinoatrial node here now in just the schematic of the conduction system. And you can see that it's passed off through several branches. Again, this will be through gap junctions. and that will spread the action potentials out through the atria. And the result, of course, of action potentials occurring in these cardiac muscle fibers of the atria is that you're going to get atrial contraction. It happens simultaneously on both the right and left hand side. The other thing, again, just to highlight, so as the atria is contracting, the action potentials from these autorhythmic fibers are going to enter into the atrioventricular node. That's where you're going to get that slowing down of the action potential propagation, because now you've gone, again, simplistic terms, but you're going from a multi-lane highway into a one-lane highway. And that slows it down and makes sure that the ventricles, again, don't contract while the atria is still contracting. So the AV node is, again, you can see it right here. It's located anterior to the coronary sinus, which we really haven't talked about much in this course, at the most superior region of the interventricular septum. So here's the interventricular septum right here. So it's just the wall of myocardium that separates the left and the right ventricle. So at the superior most region of this interventricular septum is the atrioventricular node. Again, the key point here is at the AV node, the action potential slows down considerably just because of slight differences in the cell responsiveness in the AV node versus the SA node, and the fact that those highways are converging. And again, the purpose of that is to give the atria complete time to completely empty blood into their vesicles, and ventricles, I should say. Then the action potential passes via gap junctions into this region just at the tip of the interventricular septum. This material, the action potentials, the autorhythmic fibers carrying them, is called the bundles of His, or the atrioventricular bundle, which is probably a more common terminology used now. Number 4, we get our right and left bundle branches. So you see the bundles of His at the top of the interventricular septum breaks off into left and right bundle branches. And that's starting now to bring action potentials into the ventricle. And so now the ventricle will start, presumably, hopefully, to contract. And then finally, there's these very large diameter autorhythmic fiber networks called the Purkinje fibers. And they come out of the right and left bundle branches, and they bring the action potential all the way through the main musculature of the ventricles. So this is what actually causes the ventricles to primarily contract and ultimately eject the blood from the ventricle into the major artery that they're associated with. Now, remember, the key point here is the sinoatrial node, because the sinoatrial node and the cells, to a lesser extent in the atrioventricular mode, are always depolarizing following some sort of refractory period. A refractory period, when you're talking about neurons, is the time that a neuron takes or needs to relax following a firing of an action potential. So these cells, the moment their relaxation time is over from the last action potential, they will automatically action potential again. And then they'll go through the rest, and then they'll go through another action potential, and then they'll go through the rest. It happens all the time. That's your pacemaker potential. So basically, if you look at this graph here, the combination of the refractory time and the action potential, on average, corresponds to about 0.8 seconds. So that's a 0.8 second time that your heart has to contract. And this corresponds to about 40 to 60 beats a minute, which is what is considered a pretty average heart rate. So now, I should actually mention here, because later on in this series of lectures, we're going to show you how the SA node can beat faster as a result of sympathetic nervous activity. Or slower, I guess. But you can imagine situations like, again, we talk about the axe-wielding maniac kicking down the door, and what's going to do to your heart rate? Of course, it's going to increase your heart rate. So there is absolutely a way that your nervous system can exert control over this, but it's not by causing action potentials in it. It's through some sort of control of heart rate, and ultimately also the amount of blood that gets pumped out of the heart each second. So you can imagine exercising or some sort of scary situation, and your heart rate would go up. And hormones can also have a role as well, like epinephrine, for example. So now we're not looking at autorhythmic cells anymore, but we can consider just your regular cardiac muscle fiber that requires the influx of ions from those autorhythmic fibers in order to generate action potential. So we're not looking at a graph for the autorhythmic cells, which is probably too much to talk about for this course, but I will just show you what an action potential looks like for a regular a regular cardiac muscle fiber cell. So just remember what your old action potential looks like. I'm going to, for the first time, try to use my brand new fancy pen here, but I realize it's probably not going to work. I will do that later. But you remember what an old action potential looks like. You have resting, and then there's some sort of depolarizing activating stage, and that opens up all the voltage-gated sodium channels, and you get a peak. And then they close, and then you get all this opening of these voltage-gated potassium channels, and then it drops down below resting, and then the sodium-potassium pump gets it back up to normal. Notice that for this cardiac muscle fiber here, that is not what the action potential looks like. What we see is that there's this plateau phase that separates the periods between resting. So these are called fast muscle cells because they open very rapidly as a result to threshold depolarization. So these sodium channels right here, you get a very rapid depolarization due to sodium inflow. This is when the voltage-gated channels open. So you get this influx of sodium from the outside of the cell into the inside of the cell, which is going to ultimately result in the contraction, just like in a skeletal muscle fiber. Now, at the top of this, so when we're dealing with here, of course, you know that the potassium channel is going to open at the peak of the action potential. But the other thing that's happening here is that there's a second set of depolarizing or excitatory channels. There's calcium channels that are present within this membrane as well, and they're slow to open. Okay, so when this cardiac muscle fiber is ready to undergo action potential, it will have all its voltage-gated channels, sodium channels open, causing the spike, just like in the skeletal muscle cells. This happens very rapidly because these are fast-opening sodium channels. There are also, at the start of the action potential, an opening of calcium channels as well. And if you recall, calcium is found more predominantly on the outside of the cells than inside. So if you open up a calcium channel, calcium will flood into the cell. And you should know that the movement of positive ions into the cell is a depolarizing or excitatory event. The difference between the voltage-gated calcium channels and the voltage-gated sodium channels here is that the voltage-gated calcium channels are slow to open. And this causes an influx of calcium at the top of the peak. So yes, even though voltage-gated potassium channels are opened up here at the peak of the action potential, that outflux of potassium ions is offset by the influx of calcium ions into the cell, and you get this temporary plateau phase right here where your cell is indeed losing potassium, but it's still gaining positive charge because of the calcium inflow. The final stage of this action potential is a repolarization due to the closure of calcium channels and the continued potassium outflow when the additional voltage-gated potassium channels open. So this part of the action potential occurs when the calcium channels shut down. So now you're still losing potassium, but you're not gaining the calcium, and so now you're going to hyperpolarize, and you're going to be able to drop down back to resting, and then this whole cycle will continue again. I just want to spend a minute talking about electrocardiograms, the ECGs. An ECG is a recording of electrical signals that are generated by those action potentials that we were just talking about as they move through the heart. So basically, and you're going into nursing, so you'll know more about this than I do, but basically, as far as I understand it, leads are connected to the arms, the legs, and as many as 6 different positions on the chest. Each lead then receives a slightly different signal because of the distance they are away from the heart, so it takes time for the signal to propagate. It takes a different amount of time for the signal to propagate from the heart to the finger as opposed to the heart to the leg. Again, not my area of expertise, so don't take diligent notes here. So there's like 12 lead ECGs, 3 lead ECGs, 5 lead ECGs. It just differs in terms of the number of leads you use. In my old university, I actually used to do them in the lab, and the more leads that you had, the easier it was to identify problems with the patient. So this is a typical record that you can see here. You can see basically three waves. There's a P wave right here. So voltage is on the y-axis here. So these are generated by action potential changes. So the P wave is this small little depolarization event, right? The cell's becoming more positive. This is caused by the depolarization of the atrium. So that's called atrial depolarization. And it starts to, from the sinoatrial node, migrate out through both the sides of the atria, the left and the right sides, through their contractile fibers. The next wave that you can see is the most prominent one here, which is called the QRS wave. This starts here as a very slight hyperpolarization, so it actually an inhibitory signal, followed by a very, very rapid series of ventricular repolarizations, followed by, again, a little bit of a hyperpolarization down here. And then finally, we have the T wave over here, which is a very slight depolarization again, and this is the repolarization of the ventricles. So doctors will also consider like the time span between the waves when they're looking at this. So there's like the PQ interval that you might hear of later. Here's an ST segment between these regions. Here's the SQ interval between the hyperpolarizations of the ventricular depolarization. Okay, so let's just talk our way through this. And again, we're trying to see how the action potentials spread throughout the heart and then initiate that the contraction of the heart. So we're going to try to go through the heart cycle just from the perspective of those depolarizations and repolarizations. So again, we start at the SA node. This is causing or going to spread out throughout the atria simultaneously through the left and the right atria. And that's causing the P wave. And that's going to cause the atria to depolarize, and as a result, of course, we'll start contracting. So now in this picture here, you can see the action potentials in yellow. The depolarizations are spread out all the way through the left and the right atria. Now, of course, we're now seeing that the action potentials have arrived at the AV node. Here it is at the superior most region of the interventricular septum. And again, that's going to slow down the propagation of the waves through the ventricle. Ventricular depolarization then begins, so you can see the action potentials moving down through the bundle of His and then the atrioventricular fibers, or the bundle branches, and then they're just starting to make their way up through the Purkinje fibers. This is causing the QRS complex, so now you see the big ventricular depolarization taking place. But simultaneously, and kind of masked by the enormous size of the ventricular depolarization, is the fact that the atria are now repolarizing. They're actually starting to expand or relax again. So atrial diastole is taking place at this point. Now, as you can see in the picture, the action potentials have spread all the way out through the ventricles, up through the Purkinje fibers. So now ventricle depolarization is complete. And now the wave of repolarization starts to occur, and that causes the T wave. So you can see this wave of repolarization going up through the Purkinje fibers, which is ultimately going to relax the ventricle, cause ventricular diastole, and the ventricles will get bigger, and the cycle can then repeat again. So what to focus on here, so you should be able to, of course, have a good solid working definition of the conduction system and also understand some of the key locations and regions of it. So SA node, AV node, bundles of His, bundle branches, Purkinje fibers, that sort of thing. Compare and contrast skeletal muscle and cardiac muscle. That's super important, not just in terms of how they look, but also in terms of how they function, right? So skeletal muscle works as a single individual cell. Each muscle fiber contracts independently, mostly of the other. Cardiac muscle fibers all work as a single unit. They work together in unison with one another. You should think about that and also be able to maybe compare and contrast the action potentials of the skeletal muscle and the cardiac muscle fibers. And then finally recognize that the points on the ECG are actually related to the electrical potentials, the electrical events created by those action potentials initiated by the conduction system. So when you're looking at heartbeats, ECGs on a monitor, you're actually looking at these electrical events that are carried out by the conduction system and causing action potentials in the cardiac muscle fibers. Okay, that one was a little more sloppy than the last one. I apologize. I'm still working on it. Good luck. And again, if you need any help, just feel free to contact me. Cheers.